Okay, this is an educational video on the most common adult climbing finger injury, which is the injury to the annular pulleys. If we look at the statistics on finger injuries in adults, pulley injuries are the most common climbing specific diagnosis. And I put right here overdiagnosed because it's very common for athletes to assume that they have an A2 pulley injury if there's pain in and around the pulley area. It's not always that simple, but hopefully this will give you a little bit better insight as to whether that's the correct diagnosis or not. These injuries do not only happen from climbing, these injuries also are contributed by heavy lifting. So if you're an athlete that likes to rock climb, likes to train their fingers for rock climbing, and also likes to do heavy lifting, the heavy lifting is definitely a contribution to the overall stress that would create a pulley injury. The ring finger is the most commonly injured, with the middle finger as the second most commonly injured. Typically, these injuries happen from a locking mechanism to the finger of the tendon up against the pulleys, and then a quick opening and a rotational stress all in one individual moment. So we get a rotational movement and we get lack of support. The hypothesized reason why the ring finger is the most commonly injured is because when we're grabbing on, a lot of us are doing a chisel position in which there's not lateral support on the side for the ring finger. The middle finger, by contrast, is sandwiched between the index and the ring finger, not allowing as much side-to-side rotation. The biomechanical analysis here is the ulnar abduction. So essentially, abduction means away from midline. Ulnar means towards the pinky side. So when we grab into a hold and we're pulling down and we're twisting, we're opening the hand while there's still a locking mechanism that's happening, pulling against the corner of the joint. So we get ulnar abduction and supination. During crimping, increases the stress on the ring finger. Index finger injuries are rare due to increased stress and support from the thumb. So the index finger is not as commonly injured. That does not mean that you cannot have a pulley injury or rupture even to the index finger or to the pinky finger. I see quite a few of those, much more than I would have guessed that I would see. Middle finger is supported, we already talked about that, but there's friction between the tendons and the pulleys that contribute to a lack of sustainability of the pulley to the bone. So we'll look at a picture here to give you a better understanding of what's going on. So if we look at this picture here, this is a close-up visual of the A2 pulley. And the pulley comes in a parallel alignment and attaches to the bone. But the attachment to the bone is not a parallel alignment of the collagen, it is multidirectional. So just a lot of repetitive stress of the tendon pulling away from the bone. When we're doing the half crimp position, we get a lot of pulling and twisting and stretching of the attachment to the bone. And so in the context of a rupture, the audible popping noise is the tissue popping away from the bone, and that's why we hear that loud cracking noise. Both the A2 pulley will make a cracking noise, and the A4 pulley can also make a cracking noise. Those are the only two pulleys really that will make a cracking noise on a regular basis, but there's also the cruciform pulleys, which are the smaller ones, which can also make that same cracking noise. That's less significant of an injury in recovery time. Here's a visual of a friend of mine doing that. He actually turns the other way because the hold is kind of a Gaston for him, where the mechanism that I just described was pulling down and opening the hand. He's grabbing on and turning and pronating the hand, which is the opposite direction described. So by and large, there's just a lot of variation in a climber's hand. It's very weird. All of our fingers are the different lengths. So there's a lot of stress that we put on the hands with different variations. So the presentation of a pulley injury: acute pain while crimping. So if you're half crimping, full crimping, you hear an audible pop, the foot slips, or you're shifting weight and you hear a quick opening and you hear a pop. That's a very common scenario for a pulley injury. Slip foot, campusing, rapid eccentric loads. So when you're pulling down hard and then you quickly open, the tendon is locked up against the pulley, and then the pulley can no longer sustain that load with the twisting, and it makes a popping noise from the bone. Sometimes it won't make a popping noise, sometimes it'll just make a a shifting or a shearing kind of feel on the athlete. It doesn't always have to have a pop. Commonly accompanied by an audible pop, commonly occurs and most commonly occurs to fatigue. So generalized fatigue, even though a pulley injury feels like it happened in a moment, it had been slowly accumulating over typically weeks to months of time. So it's still considered an overuse injury. It's very common to have tenosynovitis to accompany a pulley injury. Tenosynovitis is the most common overuse injury in a climber, so it goes very well hand in hand with that. Pulley rupture can happen even with minor stress, so that shows that it's a fatigue injury. So it doesn't have to be like the hardest dead point move you've ever done. It can be something pretty subtle on a small crimp, not feeling like there's a lot of stress there and a lot of force on the finger. That just demonstrates that it had been lingering in the background leading up to it. So symptoms: tenderness over the injured pulley, delayed swelling and occasional hematoma. That's usually with a rupture. Pulley sprains usually don't swell too much, but a pulley rupture will definitely swell, and you'll get swelling at the base of the finger here and then over the middle phalanx. Visible bowstring only in multiple pulley ruptures. So if you feel like you ruptured a pulley and you do some testing and you're like, I kind of feel it isolated sticking out, that's probably not likely unless you have an A2, A3 or an A3, A4. Then you might see a bit more quick curve across those tissues. Okay, sometimes it's palpable with resistance, but the more and more I communicate with athletes about their symptoms and do ultrasonography on the finger with the hockey stick probe, the more I see variations in these, where that's a really good thing to do if you have the ability to do a diagnostic ultrasound before you do a consult with me and have them get the appropriate pictures. Or if you want to schedule the consult with me and I can direct the ultrasonographer on what views to get, that also is something that I can help with to make sure we get the right diagnosis to speed up the timeline as much as possible. So here's a visual of a diagnostic ultrasound of what a consequence is of an A2 pulley rupture. So let me zoom in here so you can see it. So here's the tendon in the middle. Let me make it white. Those are the tendons. There's two flexor tendons, and here's the tendons on the top. And then the bright white structure on the bottom, that's the bone. Okay, notice how the space on the bottom, there's a space right here that isn't on the top. There's no space right there. That's what happens as a consequence of an A2 rupture. The A2 pulley, let's say now, is like here. The A2 pulley has popped away from the bone, and now it's lifted off. And now the tendon has a new mechanical pathway. It doesn't curve close to the bone as it did before. Now it goes more straight across. And so the initial part of getting this to feel better is helping just getting the swelling to go down and taking time off. And in a lot of cases, you'll wear a pulley protective splint where you push the tendon close to the bone to help to make sure you don't get more stress on the A3 and the A1 pulley. So if there's a pulley rupture, the regular recommendation for at least maybe 3-4 weeks is to wear a pulley protective splint over the A2, not over the A4, but over the A2, to push the tendon close to the bone here, like this. It needs space on the side for the blood vessels and the nerves. But the function of that is so the A1 and the A3 don't get more mechanical stress. So if my tendon curves close to the bone here, I'm not putting that much stress on the A1 and the A3 pulley. But if my tendon goes straight across, I'm probably putting more stress on the A1 and the A3 pulley. So as a means of reducing that as a problem, a lot of times people will wear a pulley protective splint with only the isolated A2 rupture. If the suspicion or we get the diagnosis that the A4 pulley is ruptured in isolation, you don't need to wear a pulley protective splint for those. And obviously that's a personal preference, but something to give you a better understanding of what an ultrasound would look like. And there's a lot more nuance to that obviously, but that's one very easy example. Here's another one showing the bone tendon distance, quite large in relation to the previous one. Okay, so things to do, like diagnosis, is rule out a fracture. So you can get a stress fracture, so in some cases we might need to order an x-ray. Doing a diagnostic ultrasound is the gold standard at this point. If you're local to me, then come into my office and we'll do an ultrasound. If you're at a distance and you have access to one and you need my help kind of directing what happens there, schedule with me and then I'll give you a write-up for the ultrasonographer to do. If you live somewhere where there's an ultrasonographer that knows climbing injuries, get that done before the call so we can analyze it and make the proper steps. MRI if x-rays and ultrasound are inconclusive, which is not that common for pulley injury. The tendon bone distance measurements, or the distance measurements here, like how big this distance is, this isn't really that relevant to you necessarily as an athlete, but we can say that like if it's greater than 2 millimeters, very sensitive and very specific for these kinds of injuries. And that's why the ultrasound is the gold standard for diagnosing these properly to get you back to appropriate training, get you back on the wall. Typical time frame for a rupture is going to be about 3 months. So I typically have people book the 12-week rehab phase so we can go through step by step and go from unloading to reloading to progressive loading back to full hard power output types of crimping.